Hello and welcome to another Piper's Pearl. Today's Pearl we're going to be looking at dizziness and vertigo. So to start off, we'll just have a look at a quick overview of the concept and the prevalence of the disorders. So when we talk about the term vertigo, it's quite easy to fall into the trap that vertigo becomes the diagnosis, but vertigo itself is not a separate disease. It's actually more of a symptom or a disease process of a bunch of different multisensory or sensory motor syndromes itself. So someone shouldn't be diagnosed with vertigo alone. It's an invitation for further investigations, if you will. Now, the prevalence of vertigo itself is around 20 to 30% of people will experience true vertigo within their lifetime. Now, to pinpoint down what we're really talking about, the difference between vertigo and something else, it really requires a good, thorough history and physical examination in order to diagnose where it fits in the broad sense. However, when you try to get a specific diagnosis of vertigo and what is actually causing the vertigo, there's a big long list of things that can cause it. That can be quite difficult, and as a result, it's quite often misdiagnosed. And what you'll find is someone will actually have to have repeated visits to the GP, and then they'll go to a whole bunch of specialists, ENT, neurologists, psychologists, across the board, before they are actually given a diagnosis, and really before they're given the proper diagnosis to support their care. So where we can play the role is if we do a thorough investigation and filter out what we can, then we can actually put them on a good pathway towards greater probability of correct diagnosis. Now, when we're talking about the causes of vertigo, the most common type of vertigo out there is something known as benign paroxysmal positional vertigo, or BPPV, that we'll talk about a little bit further as we go on with the rest of the lesson. So because I've mentioned that vertigo is an umbrella term, and there's a lot of other terms that are used and thrown out there that are often ill-defined and difficult to understand. So we'll go through a few definitions of what we're actually talking about when we say the word dizziness versus vertigo itself. So as an introduction, vertigo is an episodic and very sudden sensation of a circular motion. Now, it's either based on your surroundings or the body itself. So you either feel like you're spinning or your surroundings are spinning. Now, vertigo is often coupled with nystagmus, and 80 to 85% of all the causes of vertigo are caused by ear problems themselves or something to do with the associated ear or the vestibular nerve itself. Now, when a patient comes in and says they're suffering from dizziness, dizziness can in fact be vertigo. The patient just doesn't know it. So it is really just an ill-defined terms that covers all versions of equilibrium disorders. So dizziness should not be a term that we use as clinicians. It should be an investigation trigger into looking at what is actually going on. Now, correct terms that you can use to define dizziness further that's not vertigo, or what's been classified as pseudo-vertigos, is things like a syncope. So a syncope, as we know, they may present with varieties of dizziness and lightheadedness, in which the sensation of impending fainting or loss of consciousness is there. Now, this is most commonly caused by postural hypertension. It can be caused by cardiogenic disorders or even be drug-induced, just to look out for it. Now, giddiness, believe it or not, is actually a technical term, even though it sounds a little bit childish. So giddiness is a sensation of uncertainty and unfortunately quite ill-defined lightheadedness. In other terms, they often describe that they feel like they're swimming, sort of floating, walking on the air. They sound like the ground underneath them is disappearing, that sort of sensation. Now, it often contains no elements of rotation, no tinnitus, no deafness, no nausea and vomiting. So it's like vertigo without the accompanying symptoms itself. Now, a patient with giddiness may feel like they have difficulty walking or will have ataxia, things like that. But if you force them to walk and show their gait, they often can do so without any difficulty whatsoever. Now, giddiness is typically caused by psychoneurotic symptoms, believe it or not. Okay, so the term giddiness can be more down the line of psychoneuroses as opposed to anything physical that is going on. And the last one is disequilibrium, which is sort of the opposite to giddiness. It implies a condition in which there is a loss of balance and there is ataxia and instability whilst walking, but there is no sensation of spinning. So there is no dizziness themselves, but their gait is swaying and they're dizzy on their feet. So only whilst walking do they have this disequilibrium. Now, these are often caused by neurogenic problems, actual central problems with the brain, the cerebellum, or the surrounding connecting tissues themselves. Okay, so that's the definitions that we use when describing our vertigos and our pseudo-vertigos themselves. So taking a closer look at vertigo itself, vertigo is classified into either a peripheral or central, depending on the location of the dysfunction within that vestibular pathway. Although, in some cases, it can be classified as psychological as well. So a classic one for that is what's known as phobic postural vertigo. Now, this is one that is not common in neurologist or ENT's diagnosis, but it is coming into vogue and is actually known as the second most common type of vertigo. It's like a specialized neurological problem. Now, the characteristics of this particular one is it's vertigo in the presence of a situation that is often accompanied by anxiety. So people that find themselves in crowds, in lines, things like that, often has an increased amount of anxiety, and with that anxiety, they get this feeling of vertigo. Okay, so it's coming into vogue, is becoming more popular, quite often misdiagnosed as something else. So just be aware that while psychological is not a massive finding that you'll have in textbooks, you'll often find that with further investigations and studies, its treatment is better suited towards cognitive behavior therapy, maybe SSRIs, as opposed to traditional vertigo treatments themselves. But moving on to more classic vertigo, it can also be further defined as our objective, subjective, and we mentioned those pseudo-vertigos themselves. So objective vertigo describes when the person has a sensation that stationary objects in the environment are moving. Subjective vertigo refers to the person feeling like they're moving themselves. The third type, pseudo-vertigo, is that intense sensation of rotation inside the head as opposed to feeling like the body's moving itself. Now, if we take a closer look at the causative agents, we have peripheral and central. So peripheral vertigo is the causes and problems associated with the inner ear and the vestibular symptoms, which is composed of those semicircular canals. Now, to truly understand vertigos, you need to really understand the semicircular canals and its attaching vestibular and vestibular nerve itself. The most common cause, as mentioned, is BPPV, which accounts for about a third of all the peripheral vertigos that you'll find. Other causes is your Meniere's disease, vestibular neuritis, labyrinthitis is a common-ish one, quite often diagnosed, and also visual vertigo. Any case of inflammation, like the common cold, influenza, bacterial infection, can cause a transient vertigo within the inner ear itself. And it can also be caused by chemicals as well. For example, your aminoglycosides can definitely cause the peripheral vertigo, as too can physical trauma. Now, when we talk about motion sickness is sometimes classified as a cause of peripheral vertigo, but it's not as bad because it's associated with you being moved around. Therefore, the environment is causing the semicircular canals to be overstimulated as opposed to a pathological state. So it's a little bit hairy, but the patient feels the same. When we look at central, luckily they're not as common, but the central vertigo arise from injuries to the balance centers of the central nervous system. And this is often associated by lesions in the brainstem or the cerebellum itself, hence the term central. Now, generally associated with less prominent movement illusions and nausea than vertigo from the peripheral side. So it's a central problem, but the patient feels less disruption in their gait. So central vertigo may be accompanied by neurological deficits like slurred speech, double vision, and pathological nystagmus as well. So central pathology that causes this disequilibrium and balance disorders are often your lesions, your hemorrhage, your tumor, epilepsy, spinal cord disorders like spondylitis. Migraines are also associated with central vertigo, multiple sclerosis, and Parkinsonisms as well. Now, central vertigo may not improve or may do so very slowly compared to other peripheral problems. Now, just so you know that sometimes, even though nystagmus is a very, very common symptom of central and enforced peripheral vertigo, you can also get postural alcohol nystagmus for people that drink too much as well. So just be aware that that can be a causative factor to look out for. Moving into our subjective investigations, remember it is very important to first of all define what we are dealing with. Is it vertigo or is it a pseudo vertigo like giddiness or disequilibrium or maybe even syncope that we're dealing with? So get the patient to explain in detail what they are feeling during the episodes itself. As far as history goes, we need to know what sort of patterns of vertigo and dizziness is going through. Is it a constant with fluctuation, or is it a paroxysmal, as in only occurs with certain environments, certain situations, and for short periods of time? Find out if they've had certain illnesses to link to that inflammation that we spoke about before, and have they had any head trauma, even trivial, because all it takes is a little bit of inflammation around the vestibular nerve to cause this vertigo sensation. So it doesn't actually have to be a large head injury in order to cause the vertigo or dizziness symptoms themselves. Do they have history or family history of migraines? And you can start investigating mental health, looking at anxiety mostly, especially if the events that they're describing vertigo kicking in align with the phobic paroxysmal vertigo that we spoke about. Alcohol, as mentioned, can cause sensations of vertigo and dizziness alone. So ask social histories about alcohol intake, things like that. As far as their work life and where we actually find them, if you find them in the field in a really hot environment, you'll often find that whilst dehydration isn't a cause of vertigo, if someone has inflammation or a problem with the vestibular and semicircular canals, the dehydration and exhaustion effects can amplify the feelings of vertigo that the person suffers. So you can ask questions about that. Moving on to subjective questioning, we need to find out what accompanying symptoms the patient has with their vertigo. So very common ones are problems with the ears. Do they have tinnitus or have they experienced any deafness themselves? Is there any visual problems associated with it? Is there any associated nausea and vomiting pre or during the vertigo itself? You can ask about those neurological findings, any slurred speech, any double vision, any weakness that they found, and you can also investigate and ask questions around those psychoneuroses as well. Okay. Now, when we look at allergies, allergies are only important if we give medication, but in reality, whilst people think medications are quite popular with vertigo, most of the time, for the most probable reasons anyway, they're not very useful. Okay, so medications, allergies, that's the only link. Now, medications themselves can cause vertigo. Okay, so if you're on certain medications, then we can be a little bit investigative of whether or not that's the cause. So alcohol we already mentioned, antibiotics like your mycins, your gentamicin, your streptomycins, they commonly can cause vertigo. Antipsychotics like antidepressants, anti-epileptics can definitely do it. But even things like your antihistamines, antihypertensive, or even quinine can cause sensations of vertigo. So just ask what they're on. If you don't quite remember the full list, if it can cause vertigo symptoms, keep it in your back pocket to investigate later to see if it could be a contributing factor itself. But like I said, a good thorough history can pinpoint down mostly what we're dealing with. We'll get all the clues that we need that we can back up with objective findings to really pinpoint down the avenue of what we're looking at, most likely with the patient's symptoms themselves. But we'll discuss that further when we look at the assessment. So when we move into objective investigations, if you have no idea based on the subjective data that you've got, then you can do the complete investigation, which includes all the things that you see on the screen. If someone mentions that they have problems with a certain area, then you can pinpoint further investigation in those areas. So investigations to do with the ear is you've got to do an oroscope. You've got to have a look in there because, believe it or not, an impaction of wax or an inflamed eardrum can cause problems with the labyrinth and the vestibula itself. So have a look in there and see if there's any associated obstructions and swelling. You do a hearing test. Now in the field, you can do a hearing test by rubbing your fingers together or rubbing hair together, but you can also do a Weber's and Rayner's test if there's any associated hearing loss that the patient describes or you find itself. Now, if you don't know how to do a Weber's and Rayner's test, I'll be doing a lesson on how to conduct those separately, so just have a look out for that one. We move on to the eyes. We need to do the visual acuity and we need to do the external eye movement test in order to test for nystagmus. We need to make sure we do a full external eye movement examination in order to test nystagmus, and obviously that links to the cranial nerves that we discuss. Cardiovascular considerations, we want to do a BP, and you want to do it 3 different ways. So if you have the times, because postural hypertension and BP changes is a common cause of vertigo, you want to have the patient lying, sitting and standing, 3 different blood pressures to see if there's a massive change between them. ECGs can be handy, especially dealing with syncopes and things like that. And if you can, things like anemia can be a consideration. So hemoglobin can be something to test if you have the ability to do so. Cranial nerve test, we want to really focus on cranial nerves 2, 3, 4, and 6. That's already been taken care of by the eye examination itself. Cranial nerve 5 can be tested by corneal reflex. You don't need to do a full cranial nerve 5 assessment, but you need to check out cranial nerve 7 because it's indicative of your TIAs, things like that. Okay, so your facial nerve is an important one to test when you're dealing with vertigo. And as far as cranial nerve 8 goes, your vestibulocochlear, you really have tested the hearing one, and you can make them go through motions to test the vestibular as well. In doing so, you can look at the cerebellum as well, which is testing the gait. You can do a Sharpen-Rogers test as well. Yes, it's not only associated with med boards, it is a proper test. And you can also do a coordination. So the finger to nose test can be a good one to go through to see if there's any associated coordination problems. Now, other things you can move on to, more advanced or pinpoint sort of findings, is you can look at palpating the neck itself. So BPPV, as we mentioned, is the most common type of peripheral vertigo, and a very common cause of BPPV is actually cervical spine deformation. So if they have swelling or deformation of the cervical spine, then it can actually cause the most common type of peripheral vertigo. So palpating the neck can be an idea for any tenderness, any guarding, any stepping in the vertebra itself can be something to look into. Now the Hellpike test is something to confirm BPPV. It's a special test to confirm the presence of BPPV. If you know how to do it, definitely conduct it. I will be conducting a lesson on that and vertigo-based exercises as well. But if you don't really know how to do it, then it's best just to leave it alone. But it is the test to confirm that the patient has BPPV itself. Now, blood glucose can be done, especially if we're leaning more towards the lightheadedness and dizziness as opposed to true vertigo. And you can not assess the person's rest rate when you ask them, but just look at their rest rates associated with anxiety, because hyperventilation is also a very, very common cause of giddiness as well, associated with anxiety. So there is the complete investigation. So as you see, there is a huge array of things that you can do in order to really get some good data on what is causing this vertigo and pseudo vertigo type complaints that the patient has. Once it's all said and done, we have to make a decision of what it is. Now, hopefully by now we will know that it is vertigo. We will likely know if it's peripheral versus central, and we'll definitely know if we're talking about giddiness, syncope, or disequilibrium as well. So we'll have the big broad umbrella terms, and then we can look at certain things, certain characteristics to further define what we're talking about. So BPPV is a very short, transient sort of problem. Okay, so it's not a continuous vertigo, and it's associated with head movement. Often it's head movement back. So if the person looks up and they get this vertigo, then that's associated with BPPV. As mentioned, it can be further supported by the Hell-Pike test itself. But if vertigo on head movement is the problem and it's a transient one, then BPPV is your most common diagnosis. When you look at vestibular neuritis, now that just means inflammation of the vestibular nerve itself, caused by many different things, all those infections and inflammatory states that we spoke about, aminoglycosides, all that sort of stuff can cause vestibular neuritis. Okay, now that is where we have acute again, so very acute paroxysmal stages of vertigo with associated nausea and vomiting. Okay, so that is more likely vestibular neuritis. When someone gets the diagnosis of labyrinthitis, even though it's very common to be thrown out there, we need to have the characteristics of the exact same things that we just went through as vestibular neuritis, so the acute vertigo, nausea and vomiting, but then there also needs to be tinnitus, unilateral, bilateral, doesn't matter, and some associated hearing loss before acute labyrinthitis should be the diagnosis. Okay, so they're the most common ones that you will find. The other ones, as we move into it, is Meniere's disease. Now, I do not expect that you're going to diagnose Meniere's disease anytime with an initial examination. It takes a little bit longer, but characteristics of it is the vertigo itself is much longer. So we're talking 30 minutes to an hour episodes of vertigo itself. Whilst it has vertigo, tinnitus, vomiting, and deafness, the deafness is quite a special sort. So it's known as central neural deafness, which means that it's deafness at the very, very lower end of the tones. Okay, so you can't really diagnose it in the field without doing audiometry, further investigation, things like that. Now, if you believe it's migraine-related vertigo, now these poor buggers suffer from vertigo for hours or even days of this vertigo sensation. It only happens in people that suffer from migraines or have a family history of migraines, if you're lucky enough to find them on the first time they get this case. Now, because we're dealing with the central nervous system and all sorts of problems therein, there are a list of disorders that you sort of have to really keep your feelers out for. Now, a bunch of those are your neoplasms, your cardiac disorders, cerebrovascular, TIAs, things like that. But another one that's quite important to keep your little feelers out for is known as an acoustic neuroma. Now, this is diagnosed by an MRI, but findings you can have before to suggest that it could be acoustic neuroma is you'll have unilateral tinnitus. So tinnitus just on one side. You'll also have hearing loss on that one side, and you'll have an unsteady gait. So it's not really the vertigo that they're feeling, it's more of a disequilibrium when they start moving around, but they also have this tinnitus and hearing loss on that one side. So not classic vertigo, but definitely one to look out for if you see those symptoms. Once you have your idea, you'll want to move into your treatment. Now, education is important for this particular one because people get really scared when they have vertigo, because it almost feels like there's an external force controlling their body that makes them do things that they don't want to do. Okay, there's cases where patients will be standing still and then all of a sudden their body will contort and rotate and they'll fall over with no external force whatsoever. Okay, and that's quite scary. So reassurance that it can be quite normal and can be quite benign, this feeling of vertigo. Explain to them what is happening. And now, if you believe it's mental health related, the psychoneurosis related, then a mental health workup is the best thing to do as part of the education. Okay, remember, referral is a good thing to do as well. Restrictions are important when they're important. So if you're in a certain environment where vertigo is not conducive, if someone's doing a certain job and they do not have control over their vertigo at all, and it comes on by triggers that are associated with their jobs, then obviously restrictions to prevent and protect that are absolutely needed. Referral is a good thing when we're dealing with vertigo. Okay, there's only very, very few vertigos that you can manage and diagnose. So don't be afraid to refer after you do the good workup in order to get the further investigation and long-term management if needed. So referral to the MO, referral to the physio, remembering BPPV, most common cause is a cervical spine problem, and the treatment, spoiler alert, is actually exercises, special exercises that you can do and can be prescribed, often done by a GP or a physio itself. Don't forget that a psych referral can also be done as well. As far as the management goes, when we're dealing with BPPV, drugs are useless. Okay, when we're dealing with labyrinthitis, drugs aren't very useful either. Okay, so certain drugs that can be used and can be entertained for things like Meniere's disease, and when you have a good diagnosis, is your prochlorperazine. Okay, it's an antiemetic that has the extra effects of supporting vertigo, but it's not that amazing, and it's not very useful on many types of vertigo itself. Even though you'll hear that it's the go-to drug for vertigo, it can be useful if somebody has nausea and vomiting. It can be a good antiemetic choice because it does or could have that extra effect of supporting vertigo, maybe, depending on the type of vertigo you have. But if it is diagnosed PPVV by the Hell-Pike test, then drugs don't work, but hydration and rest does. The other thing that is actually a confirmed treatment for it is avoidance, meaning you avoid the movements, you avoid the position that causes the vertigo. So you'll find that people may describe that when they lie down, they lie on the left-hand side, they feel like the whole world's spinning, but when they lie on the right-hand side, it doesn't. So, you encourage them to lie on the right-hand side, but don't just dismiss it, because it can still be a problem. But believe it or not, it can be an effective treatment, being that this vertigo states can often last, maybe up to 7 days before the inflammation goes away and then they treat themselves. Okay. Now, the use of special exercises with a positive Hell-Pike can actually be used to treat vertigo itself. So, ESPLI exercises, which is used with clinical staff, okay, often a GP or a physio, can be a prescribed exercises, but the patient can actually go away with a Brandon and Darloff or a Crawform exercises in order to treat themselves. And the effectiveness of these treatments for BPPV can be up to 90%, with very little reoccurrence. And if there is any reoccurrence, the reconduction of these exercises can actually improve it as well. So that'll be part of the lesson to come. But just know that, believe it or not, exercise instead of drugs can be a very effective treatment for certain types of vertigo. Remember that referral is best. Vertigo, dizziness, giddiness, it's a very complex disorder that is often misdiagnosed, underdiagnosed by specialists. So there is no expectation that you will get the diagnosis firsthand after an examination in the field of someone that presents with vertigo. Okay, so if basically it's not PPPV, so it's not really a positive Hell-Pike test or it's something central related or a little bit different, then referral is definitely the way to go. Okay, that ends the lesson on dizziness and vertigo. I hope you got something out of it. Quite an interesting subject that you can go on and read a hell of a lot more on if you need to. Each one of those disorders has its own nuances and tricks and tips that you can really deep dive into. But when a patient presents and they complain of dizziness, basically an invitation for you to do a full and thorough investigation on what is likely happening to the patient and what is the best management and most likely diagnosis that patient should receive. Really comes down to you and how robust your clinical examination is. But until next time, take care.